So you want to be a registered dietitian? You are in the right place. My name is Jenny Westerkamp, founder of All Access Dietetics, and your host for Dear Future Dietitian, a podcast dedicated to helping you feel more confident in every step of your journey towards that RD credential. Thank you for being here and taking the time to listen to this episode and investing in yourself and your future career. I can already tell you're going to be a rockstar dietitian. Now let's get into it.
Hello, everyone. Thank you so much for joining today's session on nutrition support, enteral and parenteral nutrition for the RD exam. I'm so excited to have you guys today and for you guys to be watching this. It is definitely one of my favorite topics. For those of you who are new here, my name is Susie Cohen. I am a registered dietitian in Miami, Florida. I work full-time as a clinical dietitian. I'm actually the ICU dietitian in the hospital that I work at. So enteral and parenteral nutrition is something that I do on a daily basis, and I absolutely love it. I love the challenging aspect of it. I love how much it helps the individuals, the patients that are in the ICU, especially where I work. So I am so excited to share all that you guys need to know for the RD exam related to nutrition support in this video. So as always, we are going to be talking about, what you need to know for the RD exam regarding enteral and parenteral nutrition. We're going to be talking about the calculations as well. And of course, we're going to have practice questions throughout. So let's get started. Just an agenda, what we just said. We're going to be talking about the who, what, when, where, why, and how of nutrition support. We're going to talk about the different types of formulas for enteral nutrition. We're going to touch upon refeeding syndrome and enteral and parenteral nutrition calculations, including GIR calculations. And as I said, we're going to have lots of practice questions throughout. And if this were a live session, of course, we would have a Q&A session at the end. So we're going to start with enteral nutrition. So let's learn everything that we need to know about enteral nutrition. I have divided it up in the what, where, when, how, why, all that jazz. So let's start off with the what and the where. So enteral nutrition is when nutrients are supplied via a tube directly into the GI tract. So when a person cannot eat by mouth, for any particular reason, we're going to be talking about the different indications for enteral nutrition in a couple of the next slides. But essentially, when a person needs to be fed via a tube directly into their GI tract, directly into their digestive system, that is called enteral nutrition. And there are many different types of enteral nutrition. We can put a tube in a different part of the GI tract depending on the person's condition, depending on the person's anatomy. And the tube that we put in can also be either a temporary tube, a tube that they just need for a short amount of time, or it can also be something more long-term. So first, let's talk about when it would be short-term and then when it would be long-term. And then what are the types of tubes that we use for both? So starting off with the temporary tube or short term, when we know that someone just right now maybe isn't eating by mouth, and so we want to make sure that they get the nutrition that they need, but definitely in the future, they're going to be able to eat by mouth. It's just something very acute, and we can take the tube out. That is when we're going to reach for a nasal tube. So a tube that goes into the nose and then into either the stomach. So that's NGT, stands for nasogastric tube, into the duodenum, and DT, that stands for nasoduodenal tube, or NJT, into the jejunum. And it can also be orally placed. So you guys may also have seen OGT or ODT or OJT. So basically that's a tube that goes into the mouth and then into either the stomach or the jejunum. So that's a temporary tube because it's very easy to be placed. It's just threaded, usually by the nurse. I know there's some dietitians who learn how to do it, but usually it's the nurse just threads it up the person's nose into their throat, and then they place it down. They place the distal end of the tube either into the stomach if it's an NGT, or the jejunum if it's an NJT, and then they usually confirm that the tip is well placed into the organ that it's supposed to be in with a KUB or some other type of x-ray, just to make sure the tube is correctly placed. But like I said, this is temporary, this is short term, and it can be removed once the person is able to meet their needs via PO, right, via mouth. When a person needs something more long term, so I use the word permanent here because that's the way that it said it, but I don't like to think of it as permanent because these tubes can definitely be removed. They are not permanent. You can remove a PEG or a G tube, which we're going to be talking about right now. So it's not really permanent per se, right? Because they can be removed. So this is just to think about long term. I like to use the word long term. If a person needs a tube for longer, and usually the time frame is 4 weeks that we use. So if a person needs a tube for longer than 4 weeks, it's very uncomfortable to have a nasal tube in for that long. And so usually what will happen is a person will either get a tube placed endoscopically, so via like a camera that goes down the throat, or it will be placed surgically. Really, it will just depend on like the person's anatomy or what's going on in their digestive tract. That will depend on whether or not the long-term, right, tube that they're going to get is going to be placed either endoscopically or surgically. But anyways, both tubes, whether they're placed endoscopically or surgically, they're the exact same tube. So endoscopically placed, you'll have the PEG, the PEG, or the PEG-J, which is basically a tube that has 2 ports. It'll have a port into the stomach, into the gastric, in order to suction stomach contents out. And it'll also have a port into the jejunum, and that's where the feeding will usually go. It will be fed into the jejunum. The formula will usually go into the jejunal port. So these are placed endoscopically. And then you can also have these placed surgically. So you may see the words G-tube or gastrostomy tube, J-tube or jejunostomy tube, or a GJ tube. They're the exact same thing. Both these and these are the exact same tube. The only difference is one is placed endoscopically and one is placed surgically. And like I said, whether or not it's placed endoscopically or surgically is usually up to the physician, depending on the person's anatomy, their condition, if they have something blocking their throat or their esophagus, and an endoscope can't really be put in, then you'll usually go the surgical route. But again, it's the exact same tube. So those are the different types of tubes. And then usually, like I said, temporary versus long-term. But you can always remove a PEG or a G tube, let's say, if necessary. So we mentioned that the tubes can go into the stomach. They can also go in post-pylorically, so that's post the pyloric sphincter of the stomach. So they can go into the duodenum or they can go into the jejunum. When do we, go the stomach route? When do we go the post-pyloric route? Really, it depends. So gastric access or into the stomach, that's the one that's most commonly placed because, of course, it's the one that most similarly mimics PO intake. When food goes into the stomach, it'll go down all the different organs after that in order to digest the food, in order to absorb the food. And that's just how digestion happens, right? When a person's formula is going straight from their stomach into the rest of their digestive tract, that's mimicking just as if a person would have eaten by mouth. It's going through the exact same route. It's not bypassing any particular organ or any particular area. So there's maximum, absorption of nutrients. The digestive tract is working, perfectly, of course. But it's the one that's most commonly used for that specific reason, because it's just as if the person would have eaten by mouth. It doesn't bypass any organ. It doesn't bypass any absorption site. So that's why it's the one that's most commonly used. Most people can also tolerate formula directly into the stomach. We know that the stomach is a reservoir, so as long as the person doesn't have any delayed gastric emptying, gastroparesis, or an ileus or something like that, they should be able to tolerate a gastric tube with no problem. And it's also very easy to place directly into the stomach. When do we go the post-pyloric route? So that's, into the jejunum or into the duodenum. So these are some particular situations that you may see. So if someone is at risk for aspiration, we want to go below the pyloric sphincter. We want to go a little lower, just because the stomach is very close to the trachea, right? If the food is going to be, or the formula is going to be aspirated, it can very easily go and into the trachea. And so if a person is at risk for aspiration, and we know that the formula can very easily go into the trachea, and we know that aspiration can lead to a whole other set of problems, we want to avoid that, we want to prevent that as much as possible. So we may go the post-pyloric access route. And also, if someone has aspirated before on a gastric tube, we'll usually say, okay, they've aspirated before into the stomach, so let's prevent that. Let's just go directly into the jejunum this time. That way, if they are at risk for aspiration, they are less likely to aspirate because the formula is not going to go all the way up and into the trachea, because the trachea is much farther from the jejunum than it is from the stomach. So this is when is a person at risk for aspiration, let's say, when, like we said, if they've aspirated before, if they're also of older age, if they have altered mental status, if they have severe dysphagia, if they are on a ventilator, if they're mechanically vented, all of this can put a person at risk for aspiration. So these are situations where a person may have a tube placed post-pylorically. And then anatomy-wise also, if a person if the doctor is unable to access the person's stomach because they have a stomach resection, they have an esophageal resection, and like we mentioned before, also if a person has some sort of delayed gastric emptying issues, so gastroparesis, or maybe they've had prior bariatric surgery. So again, something to do with their anatomy. That's when we would want to go the post-pyloric route. Also, acute pancreatitis is a big one. I know that there's a lot of research nowadays that shows that you can feed into the stomach with acute pancreatitis, but the science behind why most individuals who have acute pancreatitis and need enteral nutrition will get a jejunal tube placed is because we know that if food, or formula in this case, goes from the stomach directly into the duodenum is going to trigger, once food is into the duodenum, that's going to trigger the pancreas to release its pancreatic juices and its digestive enzymes and all that stuff. So in order to prevent that triggering of the pancreas, which can be very painful in these individuals who have acute pancreatitis, we will usually place a tube in the jejunum. That way the formula goes directly into the jejunum and there's no triggering of the pancreas. So that's kind of the reasoning behind that. Many other reasons, these are the most common ones, but like I said before, gastric access is definitely the most commonly placed tube. And I think the next slide, this is something just very important to mention. In a J tube, so in a tube that goes directly into the jejunum, you never want to do bolus feeding. We're going to talk about different types of feeding, continuous, bolus, but you never want to do bolus feedings because of the risk of aspiration. So essentially, if you're giving too much at one time, that's basically what bolus feeding is you're giving a certain amount of formula at once. If you give too much at once, a person can aspirate. So you don't want to bolus into the J tube. And you also want to make sure that you use an elemental formula just for maximum nutrient absorption, since we are not, we're bypassing some parts of the digestive tract. We're not going to be triggering the gallbladder to release its bile, so we may affect the absorption of fat. So these are just some general guidelines that are followed with J tubes. Again, there's research that sometimes shows that this is not needed, and sometimes, but this is just general terms that I've seen for the exam specifically, so that's why I mention it. So this is just a picture, and I just show it because we talked about it in the past slide. So when we talked about one of the reasons for post-pyloric access is if someone is unable to access the stomach. So for example, if they've had an esophageal resection. So I just kind of wanted to show you that anatomy as to why you can't access the stomach with a G tube if someone has had an esophageal resection. So you see this is an esophagectomy. So this is usually how it is, right? The person has their esophagus, it's connected to the stomach. When a person, let's say, has some sort of tumor in their esophagus and they need to get it removed, they remove this whole section. And what do? Because obviously if they remove this whole section, they need to connect what's left of the esophagus up here to the stomach. They will pull it up. Like the esophagus and the stomach get joined together, the stomach gets completely pulled up into the esophagus. And so the esophagus now becomes, the stomach now becomes this long tube. And so just by looking at that picture, you kind of see how the anatomy wouldn't really be as appropriate for a gastric tube, to put a gastric tube in there. It'll usually just be more comfortable for the person, as you can see in this picture, to put a feeding tube into the jejunum, which is right here. So just as an example of when you would use a jejunal tube for this case specifically, if anatomy is an issue, right? So I just like that picture. So the golden rule of nutrition support. So now we're going to go into when you would use enteral nutrition. So the golden rule of nutrition support, which I'm sure you guys have all heard in your internships and when you took MNT, if the gut works, use it, right? We always want to make sure that if their gut is working, that we use it, because the benefits from being fed directly into our digestive tracts are like a multitude of benefits. For immunity reasons, because we do have our immune system, in a big part of our immune system in our digestive tract, to prevent bacterial translocation that may occur, to make sure that our gut doesn't atrophy if we don't use it, among many other benefits. And so we always want to make sure that if the person's GI tract is working, we use enteral nutrition and we don't go into the parenteral nutrition route, which we know has a whole other sort of complications that may occur, and we're going to talk about those. But again, if the gut works, use it. So when people use enteral nutrition, if a person has impaired nutrient ingestion or they are unable to eat solids, so for example, if they have dysphagia after they had a stroke, if a person is unable to consume adequate nutrients orally, so in this case, tube feeding is used to supplement PO intake. So if a person is eating by mouth, but they're just unable to meet all of their needs by mouth, so usually you'll see this in the older population, they can eat by mouth, but it's not like they're going to be able to meet 100% or at least 80% of their needs. And so we want to make sure that they're getting what they need. And so we'll supplement usually at night, right? Like run a little cyclic rate of tube feeding in order to meet all their needs that they need with formula with enteral nutrition. If a person has impaired digestion, absorption, or metabolism, or if a person has severe wasting, severe malnutrition, impaired growth, this is very common in the pediatric population with many conditions that may affect their growth, or with many conditions that may affect their digestion or absorption. So just thinking at the top of my head, for those of you who have seen or have worked with patients with cystic fibrosis, these patients have very high nutrient needs, and they can impair their growth very, very quickly if they're not getting all the nutrition that they need. And so a lot of the time, these kids can eat by mouth, no problem, but they will need to have that additional kind of supplementation, per se, with enteral nutrition, just to make sure that they're meeting all their needs and that their growth isn't affected. So indications for enteral nutrition, again, when oral intake is impossible, inadequate, or unsafe. So for example, if a person is intubated, we know that they have a tube going down their trachea, and so they cannot eat by mouth, and they're also, sedated and all that stuff. So that is when enteral nutrition will usually be started. If we know that the person is going to be, intubated for a longer period of time than just one day, per se, let's say. If a person is malnourished or at risk for malnutrition because of inability to maintain adequate PO, so if they're unable to eat enough by mouth, following severe trauma, burns, wounds, or critical illness, once they're hemodynamically stable. So this is very common in the ICU. So when a person comes in, let's say they've lost a lot of blood, or if their blood pressure is very low, at that point, we don't want to start enteral nutrition, because if they don't have enough perfusion to their gut at that point, right, they're losing a lot of blood, their blood pressure is low, they're not going to have all that blood that they need in order to make sure that digestion and absorption occurs. And we feed into there, then the person can get an ischemic bowel, the person can have an ischemic digestive system, and that can put them at risk for necrosis, basically dead tissue of their digestive system. And we definitely don't want that. So we only start feeding these patients once the doctor deems them hemodynamically stable, that they are able to perfuse enough oxygen throughout their body to all their different organs. And once that is, reached, usually the person will be intubated, or usually the person will not be awake, and they're not going to be able to meet their needs by mouth. So of course, enteral nutrition is going to be indicated. So that's just another example. And then what are the contraindications? So these are the times where we do not want to do enteral nutrition. And these are usually the contraindications to EN are usually the indications to parenteral nutrition. So of course, since we're feeding into the digestive tract, if a person has any of these conditions, that basically are conditions where the digestive tract is not functioning right. If the gut works, use it. So if the gut works, or if the gut doesn't work, then we don't want to use the gut. These are those situations where the gut doesn't work. So if a person has a GI obstruction, like a small bowel obstruction, if a person has severe short bowel syndrome, so if they really don't have a lot of small bowel left from a lot of resections, so they're not going to have enough absorption surface area for nutrients, right? If a person has a paralytic ileus, so let's say they have some delayed gastric emptying going on, if they have a very high output fistula, if a person has a severe GI bleed or very severe GI malabsorption, if a person just has inability to gain access, like for some anatomy reason, or they have like a volvulus where like everything is just mixed up, we obviously can't put a tube in. If a person has intractable vomiting and diarrhea, we obviously don't want to feed. So this is like very severe vomiting diarrhea. We wouldn't want to feed into the GI tract because if the person is vomiting like intractably, if we put things in, it's just going to come back up, right? So, and same with diarrhea, they're probably not absorbing any of it. And then aggressive therapy not warranted or indicated. This is a situation where, let's say it's like end stage disease, or a person is in hospice and the family says, you know what, like I just want the person to eat by mouth, like comfort care, even though we know the person is not going to be able to meet their needs. If the family just doesn't want aggressive nutrition, then of course we don't go this route. So the reasons why, we kind of talked about this, why we always want to feed into the gut, why it's so important to always use it if it's working, because once we use it, we prevent intestinal or villi atrophy, so it maintains gut integrity. It prevents bacterial translocation that can occur when we don't use our GI tract, which can lead to sepsis. Immune system support. So like I said, we have a big part of our immune system in our digestive tract. We have our gut-associated lymphoid tissue and our other sorts of immune cells that we find in our gut and in our small intestine and our large intestine. And so we want to make sure that we keep that going. And a way that we can keep that going is by feeding it and giving it the nutrients that it needs. And also because the earlier that we start, especially in critical illness, enteral nutrition, the better the person will tolerate it. So that's just another reason or another brownie point for enteral nutrition. Again, if the gut works, use it.
Imagine studying for the RD exam with an evidence-based study method, a clear study plan, access to a tutor, accountability, and expert instruction. It's all included in PassClass, the complete RD exam solution for studying with less overwhelm and more confidence. You can learn more about everything that's included in this complete program by going to allaccessdietetics.com/pass-class. Now you can hear from a recent graduate, Tanya, about her experience with PassClass.
Hi, my name is Tanya, and I bought All Access. I was gifted Inman with my program, but I didn't like the way it was set up because it was just Cliff Notes. And I read about All Access, and it really teaches you how to take the exam. I passed my exam on the first try on Wednesday, and I completely followed All Access program the way that it was explained, and I put in the time to study, and I utilized all the resources that they give you, which are a ton. Everybody there is so accommodating, and they really do go above and beyond when you have a question. And I felt really relieved that I only had one study material to use because it's really overwhelming process to take the exam. So I'm super happy I did it. I'm now a registered dietitian, and I really do thank their program and the way they teach you how to study and all the materials that they provide. So I definitely recommend it. It's worth the money 100%.
So number one is pump assisted. And this is the most common way in hospital setting. Just because a person is in bed all day, they're not really walking around or getting up. So a person can be continuously attached to the pump and get all their nutrition that way. So pump assisted basically means that the enteral nutrition formula or the enteral nutrition formula bottle is attached to a pump, and the nurse will usually set, the rate that the dietitian gives for what the goal rate for that person is. For the formula, the nurse will set it up, and the pump in itself is going to deliver that amount of milliliters per hour, right? So if we say, hey, this person's goal rate is 60 milliliters per hour, then the nurse will, put it in there. I know there's a specific word, set it up so that it provides 60 milliliters per hour, and then continuously 24 hours per day, the person is going to be getting 60 milliliters of that formula per hour. Cyclic is also pump assisted. So that's when we kind of mentioned, like when a person can eat by mouth, or when a person is, independent and they're walking around, but they just need that extra push of nutrition to meet their needs. We can just cycle their enteral nutrition to just give it for a specific amount of time during the day, not the 24 hours. So it's usually a shorter amount of time. It's a continuous feed, but it's a shorter amount of time. So it's usually 12 hours, usually like from 8 p.m. to 8 a.m. when the person is sleeping, like evening feeding. And the pro, like the advantage, is that the person has increased independence because they're not attached to that the whole day, so that they can get up during the day, they can eat by mouth, and then just when they're sleeping, we'll put the formula, we'll attach it to the pump, and we'll infuse it through their tube, and they'll get that nutrition like that just for a couple of hours, not the entire day. Now, bolus feeding is more common once a person is at home. So if a person has home enteral nutrition, or it is also very common for kids who require enteral nutrition, bolus feeding is just kind of as if the person would be getting 3 meals per day, let's say, or however many times a day that they're getting their bolus feeds, but it's kind of like giving them a large amount at one time. So it's kind of like giving them a meal, right? So it's no machines, there's no pump. It's usually, you can use a pump. I should say you can set up pumps to bolus a specific amount every couple of hours. However, because we're talking about here, like when a person is able to get up and they have independence, that's usually not attached to a pump to deliver the bolus feeds. That's usually just through a syringe. So it's just formula that's going to go into the tube through a syringe. Usually the person or another person is going to deliver a specific amount through a syringe, and it's usually a very large amount at one time, obviously an amount that the person can tolerate. So like I said, think of it as giving a person a formula like every couple of hours, kind of as if you were giving the person a meal every couple of hours. But again, it's not to be used if there is a risk for aspiration, because if you are giving the person such a large amount of formula at once, that can lead the person to aspirating that formula. So we want to be careful with that. But definitely the biggest pro is that there's increased independence. The person can go about their day during the day without being attached to a pump. And they just have to take a syringe every couple of hours and bolus the formula into their tube. The different types of systems. So open system versus closed system. So open system is just like you see in this picture here. So in an open system, the formula is poured into like a plastic baggie, and then that baggie is attached to the pump, and the formula will infuse like that. So why it's called an open system is because you actually have to open the formula can or the formula bottle, pour it into that plastic baggie, and then infuse the formula that way. So the reason why the hang time is lower, the hang time is only 4 to 8 hours, you can't run it for a very long amount of time, is because there is a risk of contamination, right? Every time that you're opening the bottle, or you're opening and you're exposing that formula to air and to oxygen, you are making it very prone to contamination, bacterial contamination. And so we want to make sure that risk is diminished in those individuals when we're using an open system. And so we don't hang it for more than 4 to 8 hours. A closed system, and that's very common nowadays because most bottles are made to be able to be hung that way, is just like you see in this picture here on the right. So all you have to do is take the formula bottle or the formula can and kind of click open the top and attach that to the tube. And the formula will pass through the tube from the bottle directly. So you don't have to really open it and pour it in somewhere and have that risk of contamination, have risk of that plastic baggie where you're pouring it in. If it's dirty, someone didn't clean it well, and that can contaminate the formula. You don't really have that risk because it's a sterile, never open bottle. You're not exposing it to the air at any time. And so you can hang it for a longer amount of time. You can hang it for 24 to 48 hours, again, because of that lower risk of contamination. So that's the difference between open system and closed system. Open system, you have to open the formula can or the bottle and pour it into a plastic bag. The closed system, you can just very quickly open the top of the enteral formula bottle and attach that directly into the tube, and there is no exposure to the open air. There's no having to pour that into a plastic baggie, so there really is a very, very low risk for contamination. The different types of enteral formulas. So you want to make sure you don't really need to know names of formulas specifically, like Jevity and Vital, which I'm sure you guys are all familiar with from your experience in your internship in MNT. But I've never really seen it on the exam. What they want to know on the exam is that you know the different types of formulas and when each one would be indicated, right? So what is polymeric? What is elemental? What is semi-elemental? What's a modular? That's really what they want to know, and that you know when you would use them. But I do like giving you guys examples here just so you guys can like kind of attach the idea to a formula that you guys are familiar with, because I know that's going to help you guys understand. So starting off with the polymeric formula, also known as a standard formula. So this is the least inexpensive formula. Sorry, that should say like least expensive formula because it's the most inexpensive formula, right? So it's really used when GI function is normal. There's not much else going on. The person doesn't really have any other diseases going on. And it's intact protein. So nothing is broken down. Everything is completely intact. And it'll usually be 1 to 1.5 calories per milliliters. So Jevity is a very common one, for example, and I'm sure you guys have all heard of or seen. And just as a little note on the bottom, just because I did talk about, it being from 1 to 1.5 calories per milliliter, you always want to choose a higher calorie per ml formula or one that's more nutrient dense for someone who has a fluid restriction, like a CHF patient or any type of patient that has some sort of edema or anasarca. Because a more nutrient-dense formula or one that's like 1.5 or 2.0, those are going to have less fluid and more nutrients, right? And so we want to make sure that we are delivering less fluid and less free water to these patients who are already having some sort of fluid retention. So for the exam, definitely want to know, because I have seen questions whenever they point out that the person is having fluid retention or edema of some sort, what kind of formula would you choose? You would choose a nutrient-dense formula or one that is higher in calories per milliliter, because the higher in calories per milliliter, the less free water. So something like 1.5 or a 2.0 formula would be best for these patients. A semi-elemental formula is also known as a partially hydrolyzed or a pre-digested formula. So this is basically when the protein in the formula is hydrolyzed into smaller peptides. So it's not a long polypeptide chain of amino acids. It's smaller polypeptide chains. It's smaller peptides. So this is used for when a person is having malabsorption or difficulty digesting and absorbing something, going on with their GI tract. And then there's also elemental. So that's completely digested, right? That's amino acid based. It's chemically defined. So that's when the protein is completely hydrolyzed into individual free amino acids. And it's used for the same reason as semi-elemental, like when a person has something going on with their GI tract, difficulty digesting, difficulty absorbing. The only difference is semi-elemental has protein chains divided into small peptides, while the elemental one is completely free amino acid. There is no peptide chains that have to be, broken down and digested. So it's definitely easier for those individuals who have some kind of digestive issues going on. Disease-specific formulas, we have formulas like renal disease formulas, so dialysis formulas, chronic kidney disease formulas for those individuals who are not on dialysis. We have diabetic formulas, trauma formulas, immune-enhancing formulas. The research is, not super conclusive for a lot of these. So the research is not super conclusive that you always have to use a diabetic formula for patients on diabetes. It's not always going to help with their blood glucose. And many other types of research, which I'm sure you guys have heard of, like the hepatic formulas, not a lot of research to back those up. The ones that are the lung formulas, I'm forgetting what they're called, but the ones that are like lower in carbohydrates, kind of to lower the respiratory quotient. which we know nowadays that there's not a lot of research to back that up either. We know that what prevents overfeeding is overfeeding of total calories, or what prevents overaccumulation of CO2 is not overfeeding carbohydrates, but it's overfeeding of total calories. So for those pulmonary formulas, that's the word I was looking for. For those pulmonary formulas, there's not a lot of research either. But again, just know they definitely do exist, and they are useful in different situations. So like the renal formulas, if a person is having high levels of phosphorus and potassium in their blood, usually a Nepro like renal formula is going to be low in those electrolytes, so that would be helpful in that case. You would just use your clinical judgment. And then modulars are the little extra proteins or extra fat that you can add to a enteral formula. So it's modular protein or fat to add extra fat or extra protein that is already provided by the formula. So let's say you just want to give the person a little more protein, not just what they're going to be getting through the formula. You can add a modular protein. You can also add some modular fat. I know there's many different things out there nowadays. There's also modular fiber. So that's what it means by modular. It's just like extra of a certain nutrient. And then what are the complications of enteral nutrition? So GI-related complications are very common, but we're going to see something in the next slide, or I think it's on the bottom of the slide. A little note about that. Clogged feeding tubes, tube dislodgement, a lot of people rip them off. Infected tubes, especially in open systems. And also, there's just like we mentioned, a risk of aspiration with bolus feeds, with gastric feeds. If a person by accident places the tube in the trachea instead of down the throat by accident. So definitely can have its complications, but they are very preventable. So here's a little note, and I'm sure you guys are all familiar with this from your internship. So the diarrhea that a person may have if they are on enteral nutrition is usually a diarrhea causing medication that's causing it. So something like antibiotics or a medication that has sorbitol in it, that's usually what's causing the diarrhea. It's not the enteral nutrition. So don't let someone blame you and say, hey, the tube feeding formula that you're feeding this person is giving them diarrhea. And then that's going to cause them to stop the tube feeding. And then the person doesn't get the nutrition that they need for a certain period of time, all because they thought that it was the tube feeding formula, while this person, if you look at their list of medications, is on 5 antibiotics, is on Miralax, Dulcolax, Senna, Colace. So, what is really causing the diarrhea, right? And then just a little general rule as well, because I know a lot of people like to check gastric residuals very frequently. Usually the guideline from Aspen is not to check gastric residuals regularly unless there are signs of intolerance. So if a person is having vomiting or emesis, or if a person has some sort of abdominal distension, or if they haven't had bowel movements in a while, maybe that's when you want to start checking gastric residuals. But if there are no signs of intolerance, there is absolutely no need to. And do not stop the tube feeds unless the gastric residuals are over 500 milliliters. If they are over 250 milliliters, you want to check it again. And then after that second time, if it's still over 250 milliliters, you want to add some kind of prokinetic agent, like a motility agent that will help things go down, such as Reglan, also known as metoclopramide. Okay, so some practice questions, and you guys, of course, can pause this so you can do it and practice it yourselves. So, which of the following types of enteral nutrition is recommended for patients who will need enteral feeding for more than 4 weeks after undergoing an esophagectomy? So, remember, this is the picture that we talked about in the previous slide. So, is it nasogastric, gastrostomy, jejunostomy, or nasojejunal? So the answer to this one is jejunostomy. So there are 2 things you want to keep in mind to this question. So number 1, it says more than 4 weeks. So that tells you that it has to be more of a long-term tube instead of a temporary tube. So not a nasal tube, right? And then also they went through an esophagectomy. So from that picture that we saw in a previous slide, we know that the stomach basically becomes a really long tube, and it's very hard to feed directly into the stomach. So we can eliminate options A and D, the nasal tubes, and we can also eliminate option B, which is the gastrostomy tube into the stomach. So that's why the answer is C, jejunostomy. And then a nurse reports that tube feeding is causing a patient to have diarrhea. The first step the dietitian should take is to initiate parenteral nutrition, to change the tube feeding formula, evaluate the patient's medications, or check for bacterial contamination. Of course, you want to always first check their medications because it is very likely that they are on a whole bunch of medications that may be causing or contributing to their diarrhea. So obviously don't initiate parenteral nutrition because their gut works fine if it's a medication causing the issue, right? You don't want to change the tube feeding formula unless it's indicated. Sometimes they may really benefit from changing the formula to something more elemental or semi-elemental. And then checking for bacterial contamination, that's also something that you may do if you can check their medications and realize that really there isn't any medication that may be contributing to their diarrhea. That C. diff is a very big problem in hospitals that can cause diarrhea. It's a hospital-acquired infection. And so that's also something that may be causing it. But again, the dietitian, the first thing you want to do is evaluate the patient's medications. So now we're going to go into the enteral nutrition calculations. So I have an example that we're going to do together, and then in the slide after that example that we do together, there are some that you guys can then do on your own. So you can just pause the video and practice it yourself using, the tools and the tips that I'm going to give you right now. So they're going to be very similar to the ones that we're going to do together. So when it comes to enteral nutrition calculations, and for the exam, guys, just FYI, for both EN and PN calculations, don't overwhelm yourselves. Usually the questions that they will give you are going to be very basic, very general, and not anything more complicated than what you're going to see here. So really don't overwhelm yourself with practicing the enteral and parenteral calculations, because usually the ones they will give you on the exam are going to be as basic as it gets. So when it comes to EN and math questions, there are two types of questions that you will need to know how to solve for the exam. So number one is, what is the rate that a patient will need a formula given the amount of calories that they need per day? So if they give you the amount of calories that they need per day and they give you the formula, then what is the amount of milliliters per hour that they need in order to get all the calories in a day? And then the second type of question is, how many calories and protein does the current rate of formula provide? So they give you, the person is getting this formula at 60 milliliters per hour. How many calories are they getting and how much protein are they getting in 24 hours and 22 hours? So those are usually the type of questions that they'll ask you. So for the first one, so for example, what is the rate or milliliters per hour that a patient will need a formula given the amount of calories that they need per day? So remember that the answer, a rate, is always in milliliters divided by hours, right? So to solve these questions, you always want to solve exactly what it's asking you for. You always want to find the top, which is the milliliters, and then you always just want to divide that by the total amount of hours that they're giving you. So you do milliliters divided by hours, and there's your answer. So really, your goal in these questions is to find the total milliliters that the person is going to get. So how do we do that? So let's do this practice question together. So a formula with 1.6 calories per milliliter is to run from 10 p.m. to 11 a.m. What rate is needed? So what is the milliliters per hour needed to deliver 1,800 calories in 24 hours? So I don't want you guys to get confused with this question. I put it because very commonly see that people get confused with this question, but I don't want you guys to be confused. So you always want to go according to when the formula is going to run from. So the formula is going to run from 10 p.m. to 11 a.m. Boom. That's the amount of hours that you're going to use to find your rate. It says what rate is needed to deliver this amount of calories in 24 hours because it's just saying, like, in a day, how many calories are they're going to get 1,800 calories. But in a day, in 24 hours, the only hours where they're going to be getting enteral nutrition is 10 p.m. to 11 a.m. So you always just want to calculate this according to the hours where they're going to be getting enteral nutrition in one day. So just because they say 24 hours here, that's really to confuse you and think that you have to calculate this based on 24 hours. But again, remember that in this situation, they're saying that the formula is only running from 10 p.m. to 11 a.m., not 24 hours. So that's the amount of hours that you're going to use to solve this question. So we have the hours, right? So again, remember that we're finding milliliters per hours. So we want to find milliliters and we want to find hours and just divide the two, and there's your answer. So for the bottom part, the denominator, the hours, we have them. They give it to us. It says 10 p.m. to 11 a.m. Once we, count how many total hours that is 13 hours. So now all we're missing is the numerator, the top part. All we need to find is the total milliliters. So to do that, we just really want to make sure that we pay really close attention to our units, right? So when we do 1,800 calories divided by 1.6 calories per milliliter, calories cross off and we're left with milliliters. So 1,800 divided by 1.6 gives us 1,125 milliliters. So now we have to do, just put that over the total amount of hours that we got previously, which is 13. So 1,125 divided by 13 hours gives us 87 milliliters per hour. So that's the rate that is needed in order to deliver this amount of calories in this amount of time. So the second type of question that we said that you could get about enteral nutrition is how much calories and protein does the current rate of formula provide? So for these questions, there's always 3 steps that you need to follow. Number 1 is find the total amount of volume or milliliters of formula that the person is going to get. So to do this, all you have to do is multiply the rate that they give you by a total amount of hours that the formula is running by, right? So if the rate is 60 milliliters per hour for 24 hours, you do 60 times 24, that's going to give you the total amount of milliliters or the total amount of volume. The second thing you're going to do after that is you're going to multiply that volume that you get in this first part by the total amount of calories per milliliter in the formula. That's going to cross off the milliliters and leave you with calories. So that's going to give you the calories. And the third thing you're going to do is you're going to multiply the total amount of milliliters times the percent protein per 1,000 milliliters, because remember that the percentages for the bottles of formula are usually given per liter. So you always want to make sure that you divide it by 1,000 to get, at the end, the total grams of protein that the person is getting. And we'll see an example now so you guys can see how you always apply those 3 steps. So calculate the calories and protein in the following enteral prescription. Pivot 1.5 at 50 milliliters per hour for 24 hours. And Pivot 1.5 contains 93.8 grams of protein per liter. So number 1, we want to find always the total amount of milliliter of formula. So what is the total amount of formula the person's going to get? We do 50 milliliters per hour times 24 hours. The hours cross off and you're left with 1,200 milliliters. So now that you have that, that is what you're going to use basically to solve question 2 and question 3 that you're going to do after that. So question 2, find the total amount of calories. You're going to do 1,200 milliliters times the total amount of calories per milliliter. That way the milliliters cross off and you're left with calories. And always the calories per milliliter is usually in the name of the formula. So if it's Pivot 1.5, that's because it's 1.5 calories per milliliter. If it's Gevity 1.0, it's a 1.0 calorie per milliliter formula. If it's Nepro 1.8, it's a 1.8 calorie per milliliter formula, and so on. So once you do that, 1,200 times 1.5, you get 1,800 calories. So that's the total amount of calories that the person is getting. And then number 3, find the total grams of protein. So again, you always start with that volume that you got in the first question. So 1,200. And then you multiply that by the total amount of protein that the person is getting per liter. But remember that it's always per liter or over 1,000 milliliters. So you always want to do 93.8 divided by 1,000 when to find that percentage. So when you do that, 93.8 divided by 1,000, you get 0.0938. So you do 1,200 times 0.0938, and that will give you 113 grams of protein that the person is getting. So with Pivot 1.5 at 50 mLs per hour for 24 hours, the person gets 1,800 calories and 113 grams of protein. So these are the questions that you guys can do for practice on your own. So I'll pause a little bit now.
Thank you for listening to this episode of Dear Future Dietitian. I hope you got a lot out of it, and I also hope that you take action based on what you learned today. Now, if you have any questions at all, please reach out to us through our website, allaccessdietetics.com, or DM us on Instagram or TikTok. We are here to help you become a more confident registered dietitian to be and make this journey way less stressful for you. So reach out, don't be a stranger, and we hope to hear from you soon. Have a great day.